My name is Angela Brand. My pronouns are she, her, and I am with the CARE TA Center, welcoming everyone into our session today on how to use MHSA funding. We are focusing today's session on support for youth programming. I will be your tour guide for today, and I am joined by some folks from Fresno County to talk about their programs. This training is offered through the Crisis and Recovery Enhancement or CARE TA Center. We are funded by the California Department of Healthcare Services. And then we have these upcoming events. We will spend a few minutes just kind of talking a little bit about MHSA and how it can be used for youth services. And then we'll turn it over to spotlight the folks in Fresno County and some of the work that they're doing. So these are your presenters for today. So just a quick refresh. What is the Mental Health Services Act, or MHSA? Proposition 63, which was enacted in 2004, created a 1% tax on incomes over $1 million, sometimes referred to as the millionaire tax. The money that goes into that account goes into the Mental Health Services Fund. The intent, as it says on the screen, is to expand and transform mental health services in California through a wide range of prevention, early intervention services. There are 5 components to the MHSA: CSS, or the Community Services and Supports; PEI, Prevention and Early Intervention; CFTN, Capital Facilities and Technological Needs; WET, or Workforce Education and Training; and Innovation. The goals here of the MHSA: reduce duration of untreated mental illness, reduce negative outcomes that may result from untreated mental illness, prevent mental illness from becoming severe and disabling, improve timely access to care, reduce stigma and discrimination, increase number of individuals receiving public mental health services, and promote a recovery vision for individuals. We do have, MHSA serves the lifespan, broken out into these populations. Defined children are 0 to 15 years, transition age youth, or TAY, are 16 to 25, adults 26 to 59, and older adults are 60 and older. And then there are some carve outs for how unserved and underserved individuals are defined. And a lot of this information is provided, maybe information that you all already know. Our topic today, and kind of framing out our discussion, there's a lot of statistics that have come out, and there's a lot of research, especially post-pandemic, around the state of mental health for children and youth. There's some statistics that are touted pretty regularly around prevalence rates. So 1 in 5 children have or will have a serious mental illness. 50% of those begin by the age of 14, and 75% by the age of 24. Some of the things that I really want to highlight in this slide is that only 20% of young people with mental health challenges are receiving services. And there's a number of reasons for that. We could probably fill a whole webinar with just some of the challenges around children and youth mental health issues. But what we are seeing is the current situation is, and has been exacerbated by the pandemic. A lot of those young people were experiencing, loss, isolation. Their, lives were interrupted. They were taken out of school. And so that has been something that folks have been, focusing a lot of time on, looking at the impacts. There's also a lot of things: social media, cyberbullying, disconnectedness, things that are compounding stress in young people. And when we think about that, the lens on top of that with structural inequity, some of the things happening socially, politically, economically, it's just kind of a lot all at once for young people. And so when we think about how we can help them, one of the challenges that we run into is a fragmented public health system. There's a number of ways to fund children and youth mental health. There's a lack of clarity in the process for how to do so. Parents and caregivers are also involved in that conversation. And so for them, figuring out how to navigate systems, also thinking about the transition for young people as they go from being a kid to being an adult, and what that system of care looks like for them on the other side, are all challenges that folks are experiencing. And so one of the carve outs to that is children that are or have been involved in child welfare or part of the foster care system. There's a lot of children that are in the system. 62,000 is one of the latest statistics. Large percentages of those children are from Black and Brown communities. And there's a whole host of significant challenges that come from their experiences. Lack of, strong and supportive relationships, placement changes in school, changes from county to county. Many of these kids are eligible for Medi-Cal services and under that have access to a broad array of services. It's a consideration to keep in mind that, in addition to just broadly serving children and youth, that there are, much higher levels of need for children that are involved in the foster care system. So the other consideration is just kind of our community mental health funding structure. We talked a little bit in our overview session in January about just the very complex way that California's system is funded and put together. It's multiple funding streams that all carry their own reporting and eligibility requirements. We're having these conversations amidst some change in California right now. There's a significant multi-year effort to reform and streamline our system, CalAIM. We also have the Children and Youth Behavioral Health Initiative that's moving through. And so we're, as the CARE TA Center, providing some information to folks all within the context of, our landscape as changing. And so just really trying to frame that out as we're here today, that this is our information that we have today. Here's where we're at. Here's what we can do. But really just keeping in mind that it's all, in the process of moving in different directions. And so think about that. We think about, serving children through Medi-Cal, through MHSA, through safety net services, just keeping in mind that while this is MHSA, we know that MHSA is kind of built into everything that we do. And so it can be kind of difficult in this and all of the conversations that we have, that MHSA is often not just like clear cut, here's just where it is, it's kind of embedded in multiple spaces. So when we think about how to use MHSA funding, like I said, this is very high level overview. One of the things that we want to be able to do to strengthen these conversations is bring in the counties to provide highlights around their programming, which is what Fresno will do here for you in just a little bit. But providing information that sets that stage. So MHSA can provide a broad array of preventative and intensive services to children and youth, including those that are in the child welfare system. Whatever the programming is, it does need to be included in the 3-year program and expenditure plan, as well as the annual updates. And these programs need to be vetted through the local stakeholder process or the community program planning process. Again, just the components that are available. Today, we're going to talk mostly about CSS, PEI, and innovation. We won't go into workforce education and training or the capital facilities funding stream. So the CSS component is the largest of all 5. The funding is used for direct services, and there are 3 components of CSS, which are the full service partnerships or FSPs. We have outreach and engagement or general system development. The services that are provided in this component are not just for the child or the youth, but they're caretakers or family members that are in need. And so thinking about things like the full service partnerships, those services are built and tailored to wrap around the whole family, and they can provide an array of options. So individual and family counseling, assessments, crisis services and support, substance use and domestic violence counseling and assistance. And for those children and youth that are also involved in the child welfare system, there is interaction and coordination with other departments such as child and family services and probation departments. So FSPs include a broad range of support and a whatever it takes, capacity, or approach. So FSP services provide child-centered and family-focused services that can be in-home and intensive mental health services for children 0 to 5 with SED or severe emotional disturbance. These can include things like counseling for children, youth, the parents, caregivers, family members as a whole, case management services, individual services and supports plans, crisis intervention or crisis stabilization services, family education, substance use disorder treatment and assistance, as well as medication monitoring, referrals for residential care, and then wraparound and other family support services. And then there's other services that are outlined as well that are not necessarily like service provision, but they're, wraparound. So things like respite care for families, wellness centers. We talk about family education, and some of this can be, employment training, employment support, leadership and skill development, and then programs for youth that may be engaged with the child welfare or justice system, can support continuity of care, such as assessment and treatment, education for caregivers, counseling, referrals, and linkage to more comprehensive mental health services. And these services can be provided in schools, homes, or in partnership with probation and child welfare. So the general system development services can include treatment, peer support, and personal service coordination. So expansion of the mental health services that we talked about on the previous slide, through things like vocational training, activity groups, that leadership or skill development, crisis intervention services, peer respite, intensive services, alternative early intervention for youth and adults, flexible alternative treatment for youth and transition age youth, family education and support, including community system navigation for families. And then outreach and engagement is the last component under CSS. And this is just outreach that can take place in a variety of settings. And that includes schools, community-based locations like drop-in centers, tribal communities, primary care providers, faith-based organizations, or outreach to individuals that include community leaders, those who are homeless or experiencing housing challenges, and those that are incarcerated in county facilities. So just a couple of different program examples, looking, through some of the different MHSA plans and seeing how counties are building their programs. We just wanted to highlight, these aren't, specific to counties, but we're not, highlighting anyone in particular. It's just looking at these examples as provided to show a lot of things are, kind of built into the program. And so there's, the school-based FSP programs. These are in accessible locations. They include individual therapy, family therapy, case management. There's a family and youth partnership program that provides services like case management, education. They do work at community resource fairs. And then Incredible Families, which is through the Child Welfare Services programming that promotes children to be reunited with their families. And the reason that we have some of these examples is really just to sort of show that there's a lot of different ways to do this programming. There's a lot of different components that go into building programming. There's a lot of way to draw down funds in different spaces. As we build out this series and as we come back to you all, working in county spaces, it's really thinking about how do we as a TA center gather as much information as we can and provide it to you in a way that helps you think about where your programming is, what kind of challenges you may be facing, different ways that you might be able to learn from what other counties are doing. So the next component is prevention and early intervention. Carve out for this is 51% of PEI budgets should be spent on individuals who are between the ages of 0 to and 25, though there is an exemption for small counties that have a population of less than 200,000. These programs are designed to focus programming in these 7 categories that are here. And so again, focus on prevention and early intervention services, education, support, and outreach. And there's a lot of opportunities within PEI to cross collaborate, within different child serving systems, to identify needs and gaps and stabilize families to reduce unnecessary child welfare or justice involvement. And counties can use funds through PEI to engage individuals prior to development of serious mental illness or serious emotional disturbance, provide supports to alleviate the need for additional mental health treatment, or support the transition of individuals to extended mental health treatment supports. And so these are just an example of some of the different types of programs that are allowed under PEI. So culturally relevant parenting or family education and support, psychoeducational groups that can address the stress factors that lead to serious mental illness, screenings, assessment, evaluation. I won't read the whole screen, but support services, linkage to services, education, specific training such as ASSIST or mental health first aid, Living Works or Safe Talk, school-based programming, hotlines, crisis lines, and a lot of these strategies can be combined into programming. PEI is a really great component when we're thinking about some of the things that we presented on just a little bit ago about, the compounded stress that young people are under and how, with post-pandemic social, political, economic climate, is really creating a lot of stress for young people and their families and communities in general. And PEI is a really great component that provides the flexibility to be able to think about how do we get to young people early before that stress really unfolds into something else. How do we get to young people when they're starting to show signs and symptoms of mental health, and how do we get to them in a way that we can transition them to a more supportive place for their health? So again, just a couple of programs, just as examples. The first one here, they're stationed at juvenile probation offices, so they provide short-term therapy and they coordinate appropriate linkage to services. There's folks that do the Wellness Recovery Action Plan or WRAP supports, 211 community hotlines that provide assessment and linkage to services. They do follow-up with the folks that call into their centers. There's Primary Care and Behavioral Health Project, which works within the primary health care space to provide support and services and linkage through the behavioral health space. And then there's specific programs that you'll find that work specifically with different populations. Here, the American Indian Project, that's working specifically to meet the needs of children within that population. So just a couple of considerations, and this is a little bit, this is connected to what we were, presenting on earlier, which is there are a lot of agencies and entities that have a hand in MHSA. And so specifically, this project is funded by the Department of Healthcare Services, but there are some things related to to the MHSA that are under the jurisdiction of other agencies. And so there are PEI regulations. Those were established by the Mental Health Services Oversight and Accountability in 2015. They do outline some data reporting requirements related to PEI. There is also some current conversation taking place about PEI priorities. We won't go into that here because that's not part of the CARE TA Center, but just things to be aware of, that there are other things moving in this space related to MHSA. The other consideration is Assembly Bill 638. This was chaptered into law and allows counties to use PEI funding for substance use disorder treatment. And so we have some information that we'll share out, these links that are on our reference page that talk a little bit more about the guidance provided by DHCS around how to use that. And I will say, just kind of planting a seed, we will be doing some additional work later in this project year to reach out and talk to counties that have started to think about how to use their PEI funds for SUD services. And then the last component that we're going to touch on is innovation. Innovation is also under the Mental Health Services Oversight and Accountability Commission, so they do approve those plans. But innovation provides a lot of flexibility for counties that are looking to try new approaches, things that haven't really been tried before in terms of reaching different populations or different communities. The opportunity with innovation is to try this out, and if it becomes something that is showing positive outcomes, those programs can transition to other funding categories such as PEI or CSS, but it does provide a really great opportunity to try something new. So I'm going to turn it over to the folks at Fresno, let them talk about the work that they're doing and highlight some of those direct examples of programs.
So my name is Maud Brahmi. I'm a division manager and also the ESM for Fresno County Department of Behavioral Health. And our team here today has worked on various parts of the MHSA plan. And so we'll be presenting on that. And what we're specifically going to present is one program in each of the components, but not each of the strategies. So as Angela detailed, within CSS, there's multiple strategies, from FSPs down to systems, to general systems development. And outreach and engagement. And with PEI, you know, we have suicide prevention, early intervention, stigma reduction, et cetera. So we're not going to do all those. We're going to do one PEI, one innovation, and one CSS for you guys this afternoon. And our focus on these is just to give you some ideas, not saying like this is the way you can do it, but just kind of showing you guys the difference in between the programs that we're operating for youth. We don't have any programs that are specifically geared for foster youth, for example. With MHSA, it's leveraged to utilize a lot of services. So instead, what we did is we focused on our youth services because we do have a number of youth programs. And these are youth programs that are either try to be as encompassing as possible, and in some instances, really kind of tailored for specific populations. So I will be kicking it off by covering an example of a PEI program that we have for youth. So the program that I'm going to just highlight here real quickly, and we'll go through and allow you guys to have questions, was a program that we call our LGBTQ pop-up. And this actually is something that we're doing under our suicide prevention. So a couple of years back during the pandemic, we were really looking at, you know, what supports and services did we have available that were specific for LGBTQ communities, whether it would be adults, older adults, youth. We just, you know, we were looking at what we could have in terms of supporting our various diverse populations. And one of the areas we wanted to focus on was something for our LGBTQ community, and working with some of our community partners. And I think that's really key when you're developing is we sat down with a couple of them and asked, and we don't have a lot in Fresno, but we did reach out with a couple locally and regionally and said, hey, you know, what are some ideas? What are some needs? What are some things that we could do, you know, to provide some form or type of mental health services that can be affirming and responsive for our LGBTQ community? And one of the suggestions actually was to create these pop-up groups. So a provider in Tulare County, The Source, had started doing those in Tulare County. They had done them in small Kings County. And so they said, well, why don't you guys do that in Fresno? Like Fresno would be the easiest place, they thought, to do something like that, just based on the numbers and number of communities and cities and things like that. And so we began doing the work, really looking at the data, looking at the research and saying, okay, well, what are we going to do if we're going to do something around pop-ups? And so we decided to focus on suicide prevention with that, based on the risk factors that our LGBTQ youth often face, put them at higher risk for suicide, although the number of completed suicides amongst our LGBT community is either extremely low or not reported because we aren't able maybe sometimes to extract that specific data. But we, you know, we thought, you know, that's where an area we thought we could do some working. And so we, you know, looked at the research. We just looked at the risk factors, and you can find any of the research out there with just a quick look. But from a number of individuals who had been bullied, a number of individuals who identify as LGBTQ who you know, did not feel welcome by their family. We saw like just really high numbers for individuals who identified as trans, and the number of them had at some point in their life or even in recent time contemplated, you know, suicide. So we're like, that's an area where we wanted to focus on. So we decided to use that pop-up model to do it. And the pop-up model is basically kind of a once a month, twice a month group. Think of like a pop-up restaurant or other thing that's a pop-up that is not initially was not meant to be like, hey, this is a full-time place, but you know, once or twice a month at various locations, there would be a group for persons who identify as LGBTQ to come in and just get some resources, feel affirmed, feel safe, and just be able to talk. And so while it was funded under our suicide prevention component of PEI, we didn't call it the LGBTQ suicide prevention group because, okay, I may come one time to a suicide prevention group to learn information and the resources, but it may not be something appealing to come in like every month. And so it being the pop-up group was something that allowed it to maybe not be as stigmatizing. And also the focus was not going to be talking about suicide prevention, you know, 12 times a year, 24 times a year, things like that. You know, there is a time where, you know, you'll talk about resources related to suicide prevention and risk factors, but a lot of it was focused on creating a safe space, like I said, and really, making it affirming. And so having things like celebrating Pride Month and talking about the history behind Pride and things like that. That's a group that, a topic, for example, for the June groups that can get them in, get them discussing and just kind of feeling safe and having those conversations and understanding a little more. And that can then in itself reduce those risk factors of someone feeling alienated, feeling isolated, not feeling safe, and those things all we know contribute to the risk factors for suicide. So by focusing on the resiliency, we actually mitigate the risk factors for suicide, and we don't have to focus on suicide every time. The idea with the pop-up group was that it would be able to be something that could be moved around. So it could be placed out of a brick and mortar location, but if you just develop community partnerships, it could move. It could come to a county building. It could come to a school. It could come to a library. So it could move around and make it potentially more accessible for maybe youth that don't live in the metro area or cannot get to it. And also looking at options for it from the beginning when we started this, it was in the pandemic, but making sure that at some point it would be something that's hybrid to where you could have the individuals who wanted to attend in person, but maybe the folks that don't live in the area and can attend to be able to participate through some type of a virtual option. And so this is a program that we started a couple of years ago. We did it for as little as $20,000 a year. It was challenging at first on the numbers, so we do have to acknowledge that because it was during the middle of the pandemic. We had just finished, I think, the first year of Zoom schooling, and so it was still being provided virtually. And so I think there was a level of Zoom fatigue, or if you want to call it Zoom fatigue, but just virtual interaction fatigue. And so the numbers weren't really high. And I believe it was like last year or this past year when they started having meetings again in person, that's where people started to come out and started to participate. And so it's not one of those things that someone has to be enrolled in, that they have to be a case manager. And I think those are some of the reasons why you're able to keep the cost really low, because it's really talking about space and staff time in prepping and then just facilitating different topics, once a month, twice a month, things of that sort. One of the things that we have worked on with this particular project is we connected the pop-up group providers with a program that Aaron will speak to later on, which is one of our school-based programs that we do in partnership with our local county superintendent schools office. And so it was a way of, how do we get this information out to youth and being able to partner with them in terms of having some of their staff that are housed and based on those campuses, sharing this as a resource, sharing this as an information with maybe students that could benefit or need something that would help support them, help with some of the resilience, and just kind of creating more of an affirming opportunity for them. So that was one way that we started to enhance this. And then Fresno was awarded through the Mental Health Student Services Act funding for community wellness centers. And so there's 4 of those throughout the county. And we've been now working with the provider that provides these pop-up groups and our partners, school partners, to utilize those community spaces at those wellness centers to be able to do the group. So the pop-ups primarily do occur at the same location, but they're now going to be moving them to where maybe once a quarter, twice a quarter, just depending on what the response is, to have them the groups move to different areas in the community. And so your cost is really associated with just some staff time, leading up to some promotions, some travel. But again, it's an example, I think, where you're able to do some prevention work for really low costs, utilizing data, working with your community partners, and really addressing a specific need or a gap maybe in your system, or addressing a high-risk population. And with that, I'm going to kick it over, I believe, to Lisa. And Lisa, you can introduce yourself.
Hello, my name is Lisa. I work for Fresno County also. I oversee a lot of the innovation projects, and this is one that we put forth right before the pandemic. So this is called Handle with Care Plus. As you can see, the budget for this was $1,527,000. Originally, it was for 3 years, but the pandemic put us a little behind schedule with kids doing virtual learning. So we extended it to a 5-year program. And The problem that we were seeing in Fresno County was there was a large amount of police calls, about 36,000 911 calls monthly, and 500 to 800 cases involve children being exposed to trauma. And so these 9,000 plus cases of children experiencing trauma were maybe not all getting services, or these were just the ones that were even reported. So Fresno County proposed a project to increase the quality of mental health services, increase access to mental health services for underserved groups, and promote interagency and community collaboration related to mental health services, support, and outcomes. And these are three of the purposes that are under innovation. So you have to have the purpose and requirements to be considered an innovation program. So we met those by meeting those three purposes. So our Handle with Care Plus project was based off of West Virginia's Handle with Care model, which was responding to children and families immediately after a trauma or life-changing event. And these events could be anything from a loss of a loved one, a fire in the house or apartment, domestic violence, anything of that sort. And so in Fresno County, we partnered with Fresno County Superintendents of Schools, Fresno Unified School District, and a local community-based organization called the Resiliency Center. And so the process behind this is Fresno PD enters calls that are with children that experience trauma, and the data gets sent to the Resiliency Center. They used to be connected to the Fresno Police Chaplaincy. And so they will triage all those calls that involve children and traumatic events and send this list to Fresno Unified School District. And the district will determine which school the kid goes to. And once they do that, the district will send a Handle with Care notification to all teachers or staff that the child sees throughout the day. This notification doesn't have any confidential information, no PHI. It basically tells the teacher just to handle this child with care today and, maybe keep an eye on them for the rest of the week and so on. And basically it could tell a teacher maybe they have a test that day. Maybe they could reschedule it for the child, or maybe, the child was up all night because there was a fire. So they could get sent to the nurse's office to go take a nap, different things like that, just to, keep an eye on them. And so we send the Handle with Care notification to all schools in Fresno Unified right now, but we're going further with 4 of our pilot schools. We're piloting 4 schools, and we chose these 4 schools based on health scores, poverty levels, student absences, crime rates, and any other environmental factors that we thought would, help us choose the best schools for this pilot. And so if the child is within the 4 pilot schools, then Fresno County Superintendents of Schools will reach out to the family to offer support. After looking in our electronic health record, if the child is in care, they will ask if we could connect to the current provider. And if the child is not in care, they will ask if they could screen and assess the child and connect them to any treatment or services if needed and if the parent agrees to it. And lastly, what makes our innovation project different than other Handle with Care models is that we have a parent cafe. We invite parents and guardians to come to the parent cafe. It teaches them about trauma and resilience through a customized curriculum that we had specifically made for this project. And it encourages family to engage in behavioral health services. And then we think that this supports youth across the curriculum or continuum, because it provides that initial response and triage. It provides assessments and screenings, or reaches out to their current provider, and also links them to care and resources. And the parent cafe is also providing the family psychoeducation and resiliency skills. So that's handled Care Plus, and now I'm gonna pass it to Erin.
My name is Erin Chan Golston. I am the MHSA coordinator at Fresno County Behavioral Health. I work under Ahmad, and I get to work very closely with Lisa. So the programs that Ahmad and Lisa presented are, I think, great examples of high impact programs that are done creatively with, not, especially that pop-up program is a $20,000 a year program, correct? Now we're gonna scale up quite a bit and look at a CSS program that has been really impactful in our community, but is also quite large. So our community support and services program that we're highlighting today is our All for Youth program. This is a program that is $25.9 million over 5 years. So exponentially larger than the programs we just highlighted. But the purpose and the goal of all these programs is the same. So this program is designed to provide one school-based integrated system of care for behavioral health service needs of youth and families. This program started about 5 years ago, and this summer is when we will transition all of the county-operated school-based services over to our Fresno County Superintendent of Schools. For those of you who I think many counties call that the County Office of Education. We call that our Fresno County Superintendent of Schools, but they're the same thing, or analogous across the state. So that the goal of that program is to eventually allocate clinical staff to all school sites in the county. I believe that we're not at 100% of the school sites, but we are in the communities. So even if somebody's not at a school site, there are the clinicians are able to go to, to travel to different school sites. So as I said, this is a collaboration between the Department of Behavioral Health and the Fresno County Superintendent of Schools. Of course, that means that we also have to collaborate with all of the school districts. It's the Fresno County Superintendent of Schools helps us make those connections, but we also work closely with the school districts that are involved. Participants must have a serious emotional disturbance or a serious mental illness for this portion of the program. We do operate a prevention and early intervention portion of this program, but for our community supports and services allocation, we're providing specialty mental health services, which requires those diagnoses. One thing that we are working on that we heard in our community planning process and that we'll be working on moving forward is to really help the community understand the eligibility criteria of this program. We've done a fantastic job getting the word out, but sometimes people are wondering why their children in particular can't receive services. So we are going to work with our partners to really highlight those prevention and early intervention services, and also to highlight the other programs that are becoming available with more state funding. And finally, to clarify what these specialty mental health services are. So that's one example of using, even though this program will continue between multiple 3-year plans, we're still able to use our community planning process to really, focus on refining elements of a program that could be strengthened. We served in fiscal year 21-22, we served 4,938 unique unduplicated children with these funds. So it's a pretty big reach. Those available services that those almost 5,000 children received include individual therapy, group therapy, intensive case management, rehabilitation, and other mental health related services. Of course, we attempt to have a variety of services that can be person driven and driven by the needs of the family and the community. Services are provided at schools, preschools, homes, and community-based settings. So overall in Fresno County, we're really making a push to provide services where people would like to receive those services. If somebody wants to come into an office-based setting, great, we'll provide services in the office. If it's easier to be at school or to be in the home or in a community-based setting like, a park or somewhere else that's been offered as a, community center or those wellness centers that Ahmad mentioned before. So the hope with this program is to continue reaching as many children as we can. We do anticipate those numbers served to go up but not significantly, but they will go up as the last schools that are being served by the internal DBH school-based services, as those programs transition to this All for Youth program, then we will see that number go up. So I believe we'll be over 5,000 unique students served every fiscal year.
If there's anything that we can provide in support of the work that you're doing, you can request TA through our website. And these are all the different ways that you can keep in touch with us. And we'll see everybody at our next session.